I'd now like to talk to you about a common pathology frequently presents to the emergency room, that of small bowel obstruction. The classic presentation of small bowel obstruction is cramping abdominal pain. Patients often report a sensation of abdominal distension, and there's usually associated nausea and vomiting. In adults, the most common cause is fibrous adhesions. This is typically due to prior surgery, though it can be secondary to prior infections or peritonitis. It's a diagnosis of exclusion on CT scan. We usually do not appreciate the adhesions on imaging. Other less common etiologies include abdominal hernias, gallstone ileus, masses within the abdomen, and intussusception. Now, this is much more common in children and is a little bit outside the scope of this talk. In addition, there are congenital causes of small bowel obstruction. Again, this usually presents in childhood, but these include things such as duodenal atresia, malrotation with midgut volvulus, and ileal atresia. So it's just some definitions. Talk about a complete or high-grade bowel obstruction, and this indicates that no fluid or gas passes beyond the site of obstruction. An incomplete or partial obstruction indicates that some fluid or gas is able to pass beyond the area of obstruction. A strangulated obstruction indicates that the bowel or that the blood flow to the bowel is compromised, which may eventually lead to ischemia, necrosis, and subsequently perforation. And a closed loop obstruction is when a segment of bowel is obstructed at 2 points along its course, resulting in progressive accumulation of fluid and gas within the isolated loop that places it at higher risk for volvulus and ischemia. Initial imaging test is often an abdominal series. This consists of a PA view of the chest with upright and supine views of the abdomen. The chest x-ray is performed to allow better evaluation of the diaphragm and search for any evidence of free intraperitoneal air. When you are looking at an abdominal radiograph, what you are trying to do is evaluate for any areas of bowel dilatation, air fluid levels, and also to evaluate the relative distribution of bowel gas throughout the bowel. This is an AP radiograph, and on this examination you can appreciate multiple dilated loops of bowel. These have continuous mucosal folds called valvula coniventes, indicating that they are small bowel. These have been reported to look like a stack of coins or a stack of discs. And you can see this in the right abdomen. This is an upright examination of a patient. This patient, you see multiple dilated loops of bowel. Again, these have a morphologic appearance compatible with small bowel. There are multiple air fluid levels, which are the straight lines across the lumen. And when you see multiple air fluid levels at different levels, this is highly suggestive of a small bowel obstruction. You also note that there is only a small amount of gas seen within the colon. And here is another case where you're unable to appreciate the dilated loops of small bowel, but again, the arrows point to multiple scattered air fluid levels. And again, when these are at multiple levels within the small bowel, rather than levels in multiple loops about the same level, it is more suggestive of a small bowel obstruction than an ileus. In an ileus, the bowel is dilated and non-functioning, and the air fluid levels tend to equilibrate, so they are often at the same level. So a more definitive diagnosis can be made with computer tomography. This can be performed with or without oral contrast, often performed without because the patients have nausea and vomiting and are unable to ingest the oral contrast material. Intravenous contrast is useful to assess for complications. The diagnostic criteria for a small bowel obstruction is to see small bowel dilatation, typically 3 centimeters or greater, and a transition point from dilated to non-dilated small bowel, which represents the site of obstruction. Here's a coronal CT scan. This patient did have oral contrast. In the lower abdomen, you can see contrast distended loops of small bowel that are dilated. They measure more than 3 centimeters. And the arrow is pointing to a small loop of small bowel that extends into a left inguinal hernia. And that this was the site of transition on this examination. So this is a small bowel obstruction due to a left inguinal hernia. Here's a coronal CT scan of a small bowel obstruction. The large arrow on the patient's left indicates a dilated loop of small bowel. Again, you can see the valvula conaventes. Note that on the patient's right side, there is an arrowhead adjacent to normal caliber loops of small bowel. So we have a transition. And centrally within the picture, there are 2 arrows at an enhancing soft tissue mass. And this was at the transition point from dilated to non-dilated loops of small bowel. So this is a small bowel obstruction secondary to an obstructing mass. And then finally, this is a patient with a small bowel obstruction. Again, this is an axial image, dilated loops of small bowel. The arrow is pointing to a rounded calcific density that was present at the transition from normal caliber to collapsed bowel. And this was actually a gallstone that had eroded into the bowel and then caused the bowel obstruction, also known as a gallstone ileus. Few more words about a closed loop obstruction. Closed loop obstruction is a segment of small bowel, as we said before, that is obstructed at 2 points. The sites of obstruction are usually immediately adjacent to one another. The excluded loop continues to excrete fluid and becomes progressively dilated. And for this reason, there is a high risk of ischemia. Here is a diagrammatic representation. The arrow points to an adhesion that is obstructing a loop of bowel at 2 sites. You have the afferent loop, which is also dilated, coming into the area of obstruction. The closed loop, which is dilated secondary to excretion of fluid, and then the collapsed efferent loop that is collapsed due to the obstruction and transition. So here is a CT scan. The arrowheads indicate 2 sites of transition. In the lower arrowhead, there's dilated loop of small bowel with an abrupt transition, and then a dilated excluded loop, which is the long arrow, and then a second site of transition with the superior arrowhead. Here's another example, more severely involved obstruction, where you see a small loop of dilated bowel with dilated bowel proximally. This examination was done with IV contrast. The wall of this loop of bowel does not enhance compared to the immediately adjacent enhancing loop of bowel in the patient's right lower quadrant. And if ischemia becomes severe, you get breakdown of the mucosal surface, and you can get air into the wall of the bladder. These arrows indicate what is called pneumatosis, where gas from the lumen has escaped into the bowel wall and mesentery, and this is a finding suggesting bowel ischemia. a note on what's called the water-soluble small bowel series. This involves an administration of water-soluble contrast instead of barium, and you obtain a series of timed abdominal radiographs over a period of 24 hours. The purpose of this is the appearance of contrast in the colon within 24 hours predicts resolution of an adhesive small bowel obstruction and indicates that the patient can be treated conservatively rather than surgery. It does have a poor ability to determine the site or etiology of obstruction. Here's an example image on the left, indicates a small bowel obstruction with a transition point at the arrowhead or at the arrow, and then in the image labeled B is a water-soluble small bowel series. I believe this was done at 8 hours, and the arrows indicate a large amount of water-soluble contrast throughout the colon, indicating passage of contrast material past the site of obstruction within 24 hours, indicating that the patient may benefit from a trial of conservative management rather than immediate surgery. Thank you for your attention.